Okay, thank you. This is the manuscript on progressions of pregnancy-induced diabetic mellitus to type 2 diabetic mellitus. It is an ambidirectional cohort study, which means that both retrospective and prospective cohort studies. So as an introduction, diabetic mellitus, it is a metabolic disorder characterized by impaired glucose tolerance, and globally it's affecting around 537 million pupils in 2021. That means equivalent to half of the African continents. And then there are different types of diabetic mellitus classifications: type 1, type 2, diabetic, gestational diabetic mellitus, and the others. And more than 19% of diabetic mellitus is type 2 diabetic mellitus. Gestational diabetic mellitus, it is a glucose intolerance first detected in pregnancy, and it usually occurs in the second or third trimester of pregnancy. And its burden varies from countries to countries. And literature suggests that in Africa, the prevalence of gestational diabetic mellitus is 9.1%. It's a high prevalence, indicating that 9 pregnant women from 100 pregnant women were affected by gestational diabetic mellitus. There are a different scenario to detect diabetic mellitus during pregnancy. You might use fasting blood glucose level greater than 126 milligram per deciliter, random blood glucose level greater than 200 milligram per deciliter, hemoglobin A1C level greater than 6.1 liters, and the gold standard is oral glucose tolerance tests. The objective of this study is to estimate the incidence of diabetic mellitus after gestational diabetic mellitus. Okay, usually gestational diabetic mellitus, it disappears, and mostly after 42 days of postpartum, but literature suggests that there is a high risk of extending to type 2 diabetic mellitus. So the objective of this study is to assess the incidence in our setup. We used both prospective and retrospective cohort study designs. We reviewed documents from 2010 to 2015 retrospectively, and from 2015 to 2009 we followed them every 3 months. Okay, and we used a simple random sampling technique to select the study participants. Study participants that withdraw from the study were considered as censored, and incomplete medical records were excluded from the analysis. And we used clinical nurses to collect the information on interview and anthropometric parameters, and we used laboratory technologies to measure the occurrence of gestational diabetic mellitus for the lab part. So, as you know, that physical inactivity is one of the risk factors for gestational diabetic mellitus. We used international physical activity questionnaires to measure whether the pregnant woman is physically active or inactive. The sample size were calculated using EPI info softwares with the assumption of 95% confidence intervals, 19% powers, 15% risks of diabetic mellitus after gestational diabetic mellitus, since we have no a valid study in our setup especially. And since it is an ambidirectional study, and we used the highest non-response rates. Descriptive statistics were used to describe the profile of study participants, and Kaplan-Meier survival curves and life tables were used to estimate the survival of study participants. Cox regressions with adjusted hazard ratio were used to declare the predictors of diabetic mellitus. So this is the profiles of study participants, just to show you from the other document. Okay. And this is the survival tables for our study participants, and using the menses as the time interval. And okay, or I will come later on. And the mean age of study participants were 28 years with 7.5 years dispersion. And the incidence density of diabetic mellitus in the GDM group was 705 per 10,355, which means that if we follow 10,355 mothers who have a history of gestational diabetic mellitus in a year, 705 of them will develop gestational diabetic mellitus in a single year, and 1,410 will develop gestational diabetic mellitus in 2 years, and around 7,000 of them will develop gestational diabetic mellitus in 10 years. This is the highest risk. In the GDM free groups, only 349 women will develop gestational diabetic mellitus in a year if we follow 25,501 women who have had no history of GDM. And I will show you the figure 2 and the table 2 later on, since I am on Zoom presentations. And after we adjust for the following variable for age, history of abortion, history of stillbirth, frequency of breastfeeding, regular physical exercise, parity, family history of diabetic mellitus, gestational diabetic mellitus, and other self-reported chronic medical illness, diabetic mellitus after gestational diabetic mellitus were determined by history of abortion, history of stillbirth, regular physical exercise, family history of diabetic mellitus, age, gestational diabetic mellitus, and frequency of breastfeeding. I will show you the supplementary file later on, since I am in difficulty of sharing all of them. So, gestational diabetic mellitus increased the risk of diabetic mellitus by 2.5 folds high. And these findings was in agreement with other research findings, like findings from Sri Lanka and others. And this is due to the reasons that gestational diabetic mellitus increases peripheral insulin resistance. Per a unit increase in the frequency of breastfeeding, gestational diabetic mellitus, okay, the risk of diabetic mellitus decreases by 28%. And this is the reason that why breastfeeding increases insulin sensitivity and improve glucose metabolism at the peripheral level. And per a unit increase in the maternal age, the risk of diabetic mellitus increases by 4%. This is because that older age increases the risk of insulin resistant and impaired pancreatic islet function. A unit increase in the parity of the women increases the risk of diabetic mellitus by 14%. And this is the reason that as the parity of the women increases, it's automatic that the maternal age increases. All those complications as the results of maternal age will present during this condition. Regular physical exercises decreases the risk of diabetic mellitus by twofold higher. And numerous findings also support these findings. This is due to the effect of exercise in preventing obesity, increasing the endocrine actions of insulin. Family history of diabetic mellitus increases the risk of diabetic mellitus by twofold higher, because diabetic mellitus or insulin secretory defects follows familial tendency. Stillbirth increases the risk of diabetic mellitus by 67%. And this is due to the reason that stillbirth disturbs the normal endocrine actions or the normal endocrine physiology of a woman. Abortion also increases the risk of gestational diabetic mellitus by 2.6-fold higher. And findings from China and other setups also agree with this research. And this is due to the multi-system effects of abortions on the cardiovascular effects of the woman, which finally predispose the woman to become obese and acquire insulin resistance at the peripheral level. So in conclusions, the progressions of gestational diabetic mellitus to diabetic mellitus was very high, and the special follow-up should be implemented for women with a history of abortions and stillbirth and family history of diabetic mellitus. And just to show you some of the supplementary files from the PDF, let me share you some PDF files so that you can, This is a PDF files which shows flow diagram for our studies, which indicated the critical action at each steps. And another very important diagram for this study is the Kaplan-Meier survival curves, which clearly indicate the risk of acquiring diabetic mellitus for the two groups, for GDM group and for GDM-free group. These are the risk of gestational, the risk of diabetic mellitus for women who have a history of gestational diabetic mellitus. This, the blue line, indicate the risk of diabetic mellitus for women who have had no history of gestational diabetic mellitus. As you clearly observe from the Kaplan-Meier survival curve, and the risk of diabetic mellitus is fast, and the magnitude is very high in the GDM group. This is the follow-up period. Why this much follow-up period? As I said, this is an ambidirectional study. Half of the follow-up were conducted retrospectively, half of the follow-up were conducted prospectively. And this, if you need a detailed explanation regarding the manuscript, you can get the online versions of this manuscript from Primary Care Diabetic Mellitus. And thank you very much. This is the end of my presentation.